Hi, and welcome to this quick start guide to menopause treatment. The intention of this lecture is to give you the tools you need to get started prescribing hormone therapy and then allow you to continue to learn from our future lectures at your own pace. My name is Kirsten Berggren. I am a primary care nurse practitioner. I also have a PhD in anatomy and neurobiology and am a Menopause Society certified provider. To start with a few disclaimers, the research into current dosing regimens and safety profiles is ongoing. A lot of the risk information that we have is based on prior dosing practices, is currently being updated as these prior doses had higher risk. So it's important to keep up with the literature, which we will cover extensively in future lectures. In terms of prescribing advice, we are presenting a few common formulations to have in your toolbox. This is by no means intended as a fully inclusive reference. There are lots of other dosings, formulations, as well as non-hormonal options to learn. Current terminology, menopause hormone therapy is the current terminology, or hormone therapy, HT. We're no longer typically using hormone replacement therapy, as the hormones are not physiologically present after menopause, so it's just considered hormone therapy. A note on language, I will use the word woman throughout for a person born with a uterus, but menopause happens to anyone with ovaries when the hormone production changes, which is important to keep in mind if you're working with transgender people who are going through this transition. So why do you need to learn to manage menopause? Well, 50% of your patients presumably are women, and those who live into their 50s will experience menopause. The symptoms can severely affect the quality of life. We're not just talking about hot flashes or night sweats. This can include depression, poor sleep, increased pain, and lots of other factors that impact long-term health. Waiting to refer someone to a specialist can needlessly delay care during a time when women are often in significant distress. So what we're encouraging through this lecture is that you learn a basic approach, and a specialist can always help with fine-tuning once the treatment has been started. Some basic information about menopause. It is defined as 1 year past the last menstrual period, so it's very difficult to pinpoint exactly when it happens at the time. The average age of menopause is 51. Typically, it occurs between 45 and 55. Age 40 to 45 for menopause is defined as early, and menopause younger than age 40 is defined as a primary ovarian insufficiency or premature menopause. But perimenopause and menopausal symptoms can start as much as more than 10 years before actual menopause. The average perimenopause starts 7 years before the last period. So if you have a woman going through menopause at age 45 and she presents to you at age 37 having symptoms, we can't just say this isn't menopause because you're not old enough. That would actually be a fairly typical age for symptoms to start. So in terms of assessment, looking at menopause symptoms, I'm going to cover first the FDA indications for hormone therapy, and these include hot flashes and night sweats, which grouped together are called vasomotor symptoms, or VMS, urogenital symptoms, and there is a urogenital syndrome of menopause, which has its own ICD-10 code, which I've included here. This includes vaginal dryness, discomfort with sexual activity, urinary discomfort and some incontinence, as well as vaginal itching. Recurrent BV can be a symptom, or recurrent chronic yeast infections. And then finally, the last FDA-approved indication is for prevention of osteoporosis. However, it has not yet been approved for treatment of osteoporosis. Looking at symptoms that are off-label indications for hormone therapy, poor sleep and fatigue is a big one. Also mood. So if you're asking women about menopause symptoms, and we will talk in a future lecture about anticipatory guidance, looking for things like increased irritability, depression, increased anxiety, these can all be signs of menopause. Many women complain of brain fog and cognitive dysfunction. It has been shown that the brain fog and cognitive dysfunction will get better on its own as a woman transitions through menopause, but this can be incredibly distressing for women who are at the peak of their career and really balancing a lot. These symptoms have high quality evidence for the efficacy of hormone therapy. The final two symptoms, weight gain and musculoskeletal pain, are also associated symptoms of menopause, but there's less evidence for the efficacy of hormone therapy in treating these symptoms. The first thing I want to cover is locally acting low-dose vaginal estrogen. This one is a no-brainer. Every woman should be educated about the availability of this option. We use either an estradiol cream or a Premarin cream. It's applied twice weekly, or you can use an estradiol tablet, again, inserted vaginally twice weekly, or there is a long-acting ring called the E-string ring, which is inserted every 90 days. It's important to note that there are two vaginal rings for hormone therapy. The E-string is low dose for locally acting, and there is another one that's a higher dose for systemic estrogen. With locally acting vaginal estrogen, there is no increased risk of systemic disease, as there is minimal absorption into the bloodstream. And this helps with vaginal and urinary symptoms. In fact, just today, I saw a 51-year-old woman who had had her 8th or 9th UTI in the past 2 years. She'd been treated over and over again. Culture often showed only normal urogenital bacteria, and nobody had thought to start her on vaginal estrogen, which of course is the prevention for these frequent urinary tract infections, especially if you're not finding specific bacteria. Vaginal estrogen can be started at any age. It can be started in a 75-year-old woman if she starts to have symptoms. It can be used alone, or it can be used in addition to oral hormone therapy for persistent genitourinary symptoms. Sometimes the systemic therapy is not enough to manage these symptoms. There's no need to discontinue this at any age. The only contraindication would be active cancer treatment, at which time you should consult with oncology. The vaginal cream comes with an applicator. That is often the reason that women discontinue this. The applicator is impossible to clean. I tell people to just throw it away, apply a pea-sized amount to the opening of the vagina and then around the urethra and clitoris. And make sure that the women you're prescribing this to understand that the purpose is for maintenance. This is not something that they only use when they're having discomfort. This is something to add resiliency to the tissues so that they're not as easily damaged. All right, so in prescribing systemic hormone therapy, we do need to look at our patient population. It should be initiated within 10 years of menopause or before the age of 60. There are increased cardiovascular risks associated with later initiation, which doesn't mean that you can't do it. It just means that you should have more knowledge and information or consult with an expert. Once you've had your correct patient demographics, you're going to want to do a routine medical evaluation, some labs, and then we'll review what the contraindications are. So a medical evaluation. This is your normal stuff. This is the bread and butter of primary care, things that you do every day. So you want to make sure that you're familiar with their medical history. Do they have a history of cancer? Do they have cardiovascular disease risk factors or a history of cardiovascular disease? Any history of unprovoked thrombosis, thyroid disorders, or diabetes? You want to know their surgical history, specifically their GYN surgeries. For example, do they have a uterus? Do they have ovaries? You want to know family history. Is there family history of hormone-sensitive cancers, clotting disorders, heart disease or stroke, and osteoporosis? In terms of social history, it's good to know about tobacco use as well as exercise, and these are primarily related to your cardiovascular risks and your clot risks. So we want to do some basic labs. As always, if somebody has night sweats and hot flashes, obviously you want to do a CBC. We want to look at a thyroid cascade, a metabolic panel, and a hemoglobin A1C. These are your same basic labs that you do for initiation of treatment for pretty much any disorder. If the patient is complaining of excessive fatigue, we certainly want to assess for sleep apnea and consider a sleep study. Knowing the menopause status is generally not needed. We're treating the symptoms, not the labs, so there's not a lot of utility in looking at estrogen levels, progesterone levels, unless you have concern that something else might be going on. An FSH can be helpful if the woman is not having periods. Otherwise, it's really not needed. And you can start treatment even if the FSH is in normal range. Reasons I would want to know FSH is, for example, somebody has a Mirena IUD and I'm treating them, for example, with oral contraceptive. Once their FSH has gotten high enough, over 25, usually I say over 25 twice or over 40 once, then I might switch them to a menopausal hormone therapy, which is a lower dose than we use in perimenopause. Treatment can certainly be initiated in perimenopause and should be if a woman is having symptoms. Contraindications for systemic therapy include any unexplained vaginal bleeding. That's going to require a workup. Liver disease, which does not count fatty liver. If they have fatty liver but their liver enzymes are pretty normal, it's okay. Any history of estrogen-sensitive cancer, including breast cancer. A personal history of coronary heart disease, so a stroke or an MI. Any personal history or inherited high risk of thromboembolic disease. And none of these are contraindications for low-dose vaginal therapy. We don't have to say never ever for women who have these contraindications, but you should seek an expert consultation if the woman really needs to have her symptoms managed. In terms of discussing risk, I think this has become a big hurdle for a lot of people when they're thinking about prescribing hormone therapy. There was a lot of publicity around the Women's Health Initiative in 2002, and this really influenced how treatment of menopause symptoms was taught in medical education over the last 20 years. I will talk about that a little bit more, but what's important, and we do this with all of the medications that we prescribe, we need to be comfortable talking about relative risk versus absolute risk. So a 20% increase in risk can sound like a lot, but if you're going from 5% risk to 6% risk, that doesn't sound like as much. You really want to be careful screening patients for risk factors, and then use shared decision-making and discussion of risk with your patients. I want to show a little bit of this data from the Women's Health Initiative because interpretation is important. A lot of the risks that were published from this study were really overblown, and the study used women from age 50 to, I believe, 89 was the oldest woman. So they were initiating hormone therapy in a population that we would not typically be initiating it in. The data was based on using conjugated equine estrogens and medroxyprogesterone acetate, which are formulations that are really rarely used these days. The newer formulations are much safer. There's no increased thrombosis risk at all with transdermal estrogen, and even in the Women's Health Initiative study, even though this image shows something different, there was no actual increased stroke risk when hormone therapy was started before the age of 59. So I'm just going to hide my image here for a second if I can. Apparently I don't know how to do that. Anyway, what I want to point out is that the risk of coronary heart disease is reduced. So over here on the right we have reduction in risk or benefit, and over here on the left we have risk. The risk of coronary heart disease was reduced with estrogen therapy. The risk of fractures was reduced with both estrogen and combined estrogen and progesterone therapy. All-cause mortality was reduced significantly, as was the incidence of diabetes. So when we're talking about breast cancer risk, I think this is the hardest part of prescribing because there is no research consensus on the exact risk levels. And it's very difficult to compare because different forms of estrogen and progestogens are used in different studies. Just a side note, the word progestogen refers to any form of a progesterone that is used for progesterone replacement. It's generally agreed that there is no increased risk of breast cancer with estrogen alone, and in fact it can be protective. Estrogen with medroxyprogesterone acetate, which was what was formerly used, gives an increase in breast cancer risk of approximately 1 woman per 1,000 over 1 year, 3 women per 1,000 over 5 years, which is approximately a 15 to 20% increase in risk over baseline. Micronized progesterone is the preferred treatment at this time, and research shows a much lower risk than with MPA, and in fact, the micronized progesterone may not increase breast cancer risk at all. So the Menopause Society, in their 2022 position statement, has put out the following as helpful ways of talking about this. The increased risk in breast cancer is less than the increase of 2 alcoholic drinks a day or obesity. Hormone therapy has not been associated with any increase in mortality from breast cancer. And as always, we emphasize the importance of routine mammography. Other risk factors: there is a small increase in the risk of gallbladder disease with hormone therapy, but there is no increase in stroke risk if started less than 10 years from menopause. And that is in patients without existing cardiovascular disease. Benefits, as I've mentioned before: a lower risk of osteoporosis, reduced all-cause mortality. There's a reduction in the progression of insulin resistance that can develop into diabetes. Estrogen therapy has been shown to slow the rate of arterial tunica intima thickening, which is a part of the progression of atherosclerosis, and hormone therapy may reduce the risk of dementia. For patients who need further evaluation, if somebody has an elevated cardiovascular disease risk, we need to be looking at that more carefully. Menopause hormone therapy is generally cardioprotective, but in women with existing plaque deposits, there is an increased risk of a cardiac event in the first year of therapy because something about the way the estrogen interacts with the lining of the arterial walls can cause existing plaques to rupture. So you want to look at your risk factors: hypertension, hyperlipidemia, and obesity. I find personally that a coronary calcium score can help in the decision making. If somebody has had hypertension or hyperlipidemia, but their coronary calcium score is 0, I will usually feel pretty comfortable prescribing them hormone therapy. We need to also look at women who may have an elevated thromboembolic risk. There is an increased risk of clotting with oral forms of estrogen. This is not shown in the transdermal forms. So if I have a patient who is a smoker, a patient who is obese, a patient who has reduced mobility or a pretty sedentary life, I will always go with a topical form. So now we get down to the nuts and bolts of how to prescribe. And it's really not that complicated. If you can prescribe birth control, you can definitely prescribe hormone therapy. So there's a few decisions that we have to make. One is, are we going to do oral or transdermal estrogen? I always try to steer people towards transdermal just because of the lower risk profile, and especially if I have a woman who's been on hormone therapy for a while but is now over the age of 60, I will try to convert her from oral to transdermal, again, because of the lower risk profile. Are we going to do estrogen only or an estrogen-progestogen combination? And we'll talk about that. We need to select which kind of a progestogen we're going to use, and are we going to do local versus systemic therapy? Well, we've already talked about local therapy, so now we're going to be talking about systemic. So here are some basic estrogen products just to kind of have on your quick select list on Epic or however you like to do these things. So the most commonly used is the 17-beta estradiol patch. The 17-beta estradiol is the bioidentical to the estrogen that our bodies produce. This is a once or twice weekly patch application. The starting dose is either a 0.025 or 0.0375 milligrams daily. I would say the most typical dose is a 0.05 milligram daily, but we always want to start a little bit lower. And I find that if your patient comes back and says that she's feeling great, having really good improvement, but that she feels the estrogen wearing off before the next patch, that's an indication to go to a higher dose. One pro tip that I give women is don't put this on right out of the shower. If your skin is warm and moist, the patch won't stick as well, so wait for your skin to cool. But I find in general most people don't have trouble with the adhesives. These tend to stick really well. There's also, as a topical therapy, the vaginal systemic therapy, which is called a Femring, which is an estradiol acetate. This is changed every 90 days, and the initiating dose is a 0.05 milligram per day, which is the lowest strength it comes in. If you're going to be prescribing oral estrogen, again, we have the option of the 17-beta estradiol as the bioidentical. Typically, the lowest dose you can find this in is a 0.5 milligram per day. I very rarely use conjugated equine estrogens because of some increased thrombotic risks, but these sometimes have broader effects. And so if you're not getting complete symptom relief with the 17-beta estradiol, occasionally this one will be one that I try. I don't have people on it for too long because it does have that higher risk profile, and the starting dose is initiated at a 0.45 milligram per day. So that's prescribing estrogen. Pretty straightforward. You need to individualize your therapy, start low, increase until symptoms are managed, monitor for side effects. There's no way to predict what dose is going to work because there's a lot of genetic differences in the bioavailability. And as a woman progresses through her menopause transition, you may need to raise or lower the dose multiple times over several years. The timing of efficacy, there's not a lot of research on the efficacy for mood, but from personal experience, speaking with my colleagues, it does seem like the mood improvement can be very rapid, within a few days to weeks. Hot flashes take a little bit longer, between 4 to 12 weeks to really notice an improvement, and the urogenital symptoms, it's up to about 3 months to notice improvement. And again, with systemic estrogen, you may also need to add a topical to help with the urogenital symptoms. Side effects, the most common ones are sort of like feeling like PMS. So breast tenderness, nausea, bloating, fluid retention, mood swings, and then more typically with the progestogen levels, some breakthrough bleeding or headaches. And we'll talk a little bit more about that with the progestogens. So if a woman has a uterus, she needs to also get some form of a progesterone therapy, because what estrogen does is it causes the uterine lining to thicken and it increases the risk of endometrial cancer. Many women find that an oral progesterone at bedtime helps with sleep onset and quality. Progesterone can be a relaxing hormone, but you need to really personalize this to the patient needs and her response to the medication. So when possible, I don't like to start 2 medicines at the same time, right? Because you don't know what the side effects are. So try to separate the initiation of the estrogen from the progesterone by 2 to 4 weeks. It's okay to start the estrogen first, which is what I typically do, because I'm usually treating vasomotor symptoms or mood or irritability. So that's when I would start the estrogen first. I start the progesterone first if somebody's primary concern is either trouble sleeping or they're just having really heavy bleeding going through perimenopause. And starting the progestogen first can help with that bleeding, just like we do in younger women who are having menorrhagia. So progestogen options. If somebody doesn't want systemic progesterone, the progesterone-only IUD, the Mirena, is the best option. This is off-label use, but it has shown good uterine protection without any systemic progesterone. Micronized progesterone, or MP, as opposed to MPA, is the oral bioidentical, and this has the lowest risk profile of any of the progestogens. There is also a vaginal progesterone, which I'll talk about in a little bit. We have the medroxyprogesterone acetate, which sometimes you will see prescribed. If I inherit a patient who's on MPA, I will try to switch her over to micronized progesterone. And then there are also combination pills and patches that have both estrogen and progesterone in a single delivery system. So progesterone dosing, the easiest thing, 100 milligrams micronized progesterone at bedtime. That's it, you're done. Now, some people don't like how the progesterone makes them feel, and they want to take it less often. So there are options for that. Some women get headaches with progesterone. Some women have some moodiness with progesterone. And so again, that's why I start it separate from the estrogen when I can. If you're doing cyclical dosing of progesterone, so a certain number of days per month or per quarter, there's a higher risk of uterine bleeding when the progesterone is removed, because the progesterone inhibits the buildup of the uterine lining. But some women prefer to do this, and there are a couple of options. One option is 12 to 14 days a month at 200 milligrams. There's an option of a minimal frequency of 12 days every 3 months at 200 milligrams, but this doesn't have great evidence behind it in terms of providing adequate uterine protection. And so for someone who's really not tolerating progesterone well and wants to do this minimal option, I would monitor with a pelvic ultrasound every year. All right, so the only problem with micronized progesterone is that it's manufactured with peanut oil. So someone with an anaphylactic peanut allergy, this is just off the table. So we have a couple of options for them. There are combination patches. These in Epic tend to be very hard to find, so you sort of have to know the brand name to find them. The Combi Patch and the Climera Pro are our two options, and they don't have much dosing flexibility. So they're both at about that 0.05 milligrams of estrogen. The Climera Pro is 0.045. And then the Combi Patch has an option of 2 doses of the progestogen, which in this case is norethindrone. There's also an option for a topical progesterone. This can be done as a vaginal insert, which is a little capsule, 100 milligrams a day, or a vaginal gel, which comes in a 4 and an 8% with a dose of 45 or 90 milligrams. If you're doing the higher dose, 90 milligrams, you can do every other day. You can do the 12 days a month. It's really about what your patient is going to adhere to, just like everything else we do, right? So monitoring. You need to raise the estrogen dose if symptoms aren't relieved. That's pretty straightforward. You don't need to necessarily change the progesterone dose, although I will sometimes increase the progesterone dose if somebody is having a lot of bothersome bleeding. If they're not tolerating an increase in the oral progesterone, you can combine, but typically I'll just go to 200 milligrams of progesterone daily, and that really helps control the bleeding. If there are side effects, you try to lower the dose to the point where you're getting symptom management without side effects. If a woman is having increased uterine bleeding on hormone therapy, that will typically resolve within 6 months. If it's persistent, you're going to want to get a pelvic ultrasound, but it's okay to kind of let it ride for a little while. So when do we need to stop hormone therapy? There is no set age for discontinuation. The Menopause Society used to have, quote, lowest dose for shortest duration, unquote, as their recommendation. This has been removed in their 2022 guidelines. With many women, bothersome symptoms may return with discontinuation. Osteoporosis risk will increase with discontinuation. But the breast cancer risk does appear to be cumulative with duration of treatment. So again, something to keep in mind and discuss on an ongoing basis with your patient. Research is ongoing. Keep an eye on it. It may be that the current forms that we're using are not actually associated with an increase in breast cancer risk. And with everything, shared decision making is essential. So I think that you'll find that this is straightforward, essential, and satisfying work. I always feel such an incredible sense of satisfaction when a woman comes back to me who's really been struggling. She doesn't know why she's so anxious. She doesn't know why she's so irritable. She hasn't been sleeping well. She's had hot flashes all the time. And she comes back to me for that 2-month follow-up and is feeling so much better. So I really encourage you, get out there, start prescribing hormone therapy, and I think you'll find it to be really satisfying work. So here is my message to you. Go forth, practice menopause medicine, and we will be continuing this educational series with a number of new lectures, so stay tuned. And here are some references. Obviously, this is not an exhaustive list, but these are some references you can refer to if you want a little bit more information about many of the topics that we've talked about today. Thank you so much.